There are several different cases where 3D axial separation may not be the most appropriate approach to initially managing a primary disc-related disorder. When you have patients, because of the location of their disc lesion, are not tolerant of 3D axial separation, such as a lesion where the protrusion or prolapse is in the axilla of the nerve root, and they don't tolerate the side bending associated with 3D axial separation and extension or flexion, or you have a patient where all movements are painful, or you have a case where their symptoms are resolving, but their lateral shift is persistent, we may want to use a flexion combined technique, or the technique according to Dallison. For this technique, we're going to ask that the patient is supine. We're going to put several parts of prepositioning together in order to get the patient in a position of flexion and combined rotation with side bending. To start out, we're going to ask the patient to be positioned with the knees flexed. We're going to be treating, in this case, her right side. We're going to first cross the left leg over. I'm going to also position her left arm over her chest. Then I'm going to reach between her legs to her pelvis while supporting her right knee on my shoulder. In this position, I'm going to proceed to slowly and methodically bring her right hip into 90 degrees of flexion while I give her a manual posterior pelvic tilt. In this position, I'm going to open her right side up with side bending of the pelvis, through the pelvis. Then I'll take my left knee and place it under her left ischial tuberosity. By placing my knee there, now I can change my position and not lose the side bending I just achieved. I'll then stand up while supporting the leg, place my hand under her right popliteus, shift my weight more towards her shoulders, and now as I begin to rotate and flex her lumbar spine, I can step off the table and while supporting her right shoulder. I will take it up to a point where either she shows increased symptoms or I reach an increased stiffness in her infeel. At that position, I'll back off a bit and then support her in that position for up to 5 minutes. I can keep my hand on her shoulder if she shows a tendency to rotate. At the end of 5 minutes, holding her there, or her intolerance of the position, whichever comes first, I'll then return her back to the starting position, but I'll do it in a way where I unwind those fundamental positions that we just brought her through. To do so, I will then de-rotate her and take out some of the flexion. I'll rest my shoulder against her knee once again, placing my hands on her pelvis, hip flexion on the right side. Slowly take out the side bending and then lower her down till her foot is on the mat. Then I'll uncross her legs and straighten out one leg at a time. I'll go back, retest her functional exam movements and/or her dural tests.